Welcome everyone, this is Valerie Cape at CMQCC. We welcome you to today's webinar. We wanted to give you a few announcements. All participants are muted, so please use the Zoom question and answer feature to ask any questions anytime throughout the presentation, and we will address them at the end. Today's webinar is being recorded and it will be archived within several days on CMQCC's YouTube channel. And if you have any questions, you can follow up with me at vcape@stanford.edu, and we will get back with you with responses. While you wait as we get started, we'd like to have you answer a little poll. There's 2 questions to tell us a little bit about you so we can understand our audience better today. And I have just launched it, so you'll be able to look at it really quickly as we get started. Again, thank you for joining us. At this time, I'm going to turn the webinar over to our speaker, Dr. Elliott Main. He is the Medical Director at CMQCC, and he has been instrumental in developing the PCO6 measure, understanding the newborn complications, unexpected newborn complications. So with that, Elliott, I'll turn it over to you.
Thank you, Valerie, and good afternoon, and welcome to this discussion. We have an unusually high number of registrants here today, so if you know friends aren't able to log in, we would be welcome to send them to the archive site. What we're going to talk about today is the unexpected newborn complications measure, which has recently been adopted by the Joint Commission starting with first in January. This is a measure that we've used for many years in California, in Oregon, and Washington, so we have a lot of experience with it. I'd like to start with acknowledgments of the co-developers of this. This has been an effort that's been jointly between obstetrics and neonatology, and with a lot of data analytics provided by Shen-Chi Chang and Anisha Abrero. None of us have any conflicts of interest or disclosures to report. So, unexpected newborn complications is a term neonatal composite outcome measure. The measure simply asks of baby without pre-existing conditions, i.e. we've discarded preemies, we've discarded multiple gestations, birth defects, or other fetal conditions, and are asking only among those that are normally grown and were not exposed to maternal drug use, how many of these normal babies had severe or moderate neonatal complications? This was first developed and tested beginning in 2010 by CMQCC in conjunction with CPQCC, our neonatal sister organization. It's been extensively field tested over the next 7 years and used in state quality improvement projects, not only in California, but in Washington, Oregon, and Florida, and by the National Perinatal Information Center based in Providence, Rhode Island, all told averaging over 750,000 annual births. NQF, the National Quality Forum, endorsed this measure in 2010 and re-endorsed it in 2016. Early in this year, the Joint Commission evaluated unexpected newborn complications and chose it as PCO6 in their perinatal core measure set, and have issued full specifications for reporting for all their perinatal sites, starting with January 2019 births. So let's step back and ask, from the family standpoint, what is the most important pregnancy outcome? And it's clearly what I always called as an obstetrician, a good take-home baby. This is more important than avoiding a cesarean or an episiotomy or even avoiding maternal morbidities. The focus on maternity care is having a good baby that you're going to take home and raise. That's what the goal of pregnancy is all about. We've not had a measure for that for many years. And so it's simply an important question to say, if baby outcomes are so important, why were we not measuring them? Some of the historical issues have been which babies should be in such a measure, what outcomes would be important to measure. Among term babies, there's a low rate of poor outcomes that makes the measure a little bit more difficult to operationalize. And lastly, are the poor outcomes among term babies actually related to obstetric or neonatal care? So let's look at some of these questions. Which babies? So all babies versus just term babies is the first question up. Preterm babies, preterm infants have a wide range of outcomes related to gestational age and birth weight. A 35-weeker is very different than a 28-weeker, which is in turn very different than a 23 or 24-weeker. Hospitals vary quite a bit among their rates of preterm birth. And this overall is not a homogeneous group. Congenital malformations also vary in their rate from hospital to hospital, and they're very closely tied to infant outcomes. Together with pre-existing conditions is an important principle. Some populations are really not expected by the family or parents to have perfect or great outcomes. What we really want to focus in on the ones that are expected to have good outcomes and see what happens with those. So there have been two fairly widely considered prior attempts to measure term baby outcomes. One is the rate of term baby NICU admissions, or as health plans like to look at it, how many days do their term babies spend in the NICU, i.e. NICU lengths of stay. But as the audience probably recognizes, that NICUs vary greatly from hospital to hospital in their admission criteria. And sometimes, and actually fairly often, even internally by the shift. Night shift may have different criteria than day shift for who goes into the NICU based on staffing on the transition or the well baby nursery. Or it may vary by census, i.e. if the well baby nursery is packed, they may not be able to do evaluations, and those babies then may be admitted to the NICU. Secondly, there's a big difference between a baby sent to the NICU for observation versus a confirmed diagnosis. And that may or may not appear in the coding algorithms or in the length of stay. Well, lastly, NICU admission per se is not an external code. So it has to be a supplemental code to have it be in a population-based data set for use for quality improvement. The second approach to term baby outcomes is the ARC, Patient Safety Indicator 17. The ARC indicators were all designed to be collected with administrative data and was really essentially a first pass at doing population level quality measures for all hospitals in the United States. So ARC PSI 17 is the birth trauma rate, and it's birth injuries to the infant, not birth trauma rate to the mother, which is a different PSI for 3rd and 4th degree lacerations. So PSI 17 was defined in the early 2000s, or the late 1990s even, and looked among the totality of birth injuries, all trauma to the infant, which is shown in the pie diagram on the left. And you can see 2/3, 78% of all birth trauma was injuries to scalp. The black 78.24%. These are the ICD-9 codes that corresponded to it. And this, of course, represents cephalehematomas, maybe even some capits. So the quarter that's left, of the quarter that's left, is only 9% that went on to become PSI 17. They excluded in PSI 17 fractured clavicles, injury to brachial plexus, and facial nerve injuries, even though some of those, particularly brachial plexus injuries and facial nerve injuries, are of significant concern to parents and family. So then looking at the right-hand pie diagram, the underlying issue with PSI 17 is that almost 2/3 of the cases fall into that first category, underlined in red, which is other specified birth trauma. As a researcher and a quality improvement leader, I always hate codes that begin with other, because it covers all kinds of diagnoses, big and small, and it is variably coded. It's often dependent on the hospital as to what gets included or excluded in that. So that's a significant issue. It also includes, though, intracranial hemorrhages, other injuries to skeleton, which is pretty rare, but other, again, is a problem because that could be major or minor. And it's the epicranial subaponeurotic hemorrhage, which is otherwise known as subgaleal hemorrhage, is an important one there as a complication largely of vacuum extraction. Now, in the numbers to the right of this slide, you see all trauma. The big pie on the left occurs 25 per thousand, 25.9, or about 2.5%. PSI 17 is only 2 per thousand, so it's a pretty small number to begin with. And remember, of that 2 per thousand, 2/3 are other, and that leads to potential significant variations that have nothing to do with care. The bottom numbers there show that actually there's more PSI 17, more birth trauma that occurs with C-sections, i.e. the odds ratio is 1.7 times higher with C-section than vaginal delivery, which is really kind of an interesting phenomenon. It may not be, therefore, as reflective as what we think face validity-wise. So the critique of PSI 17, so it's a very small subset of all birth traumas, very low rate, 2 per thousand, dominated by non-specific codes, easy to show improvement by adjusting coding practices for other birth trauma. And this appears to be what happened with units or systems that showed improvement, is that they were able to improve their coding rather than their actual care for their babies. And of course, birth trauma is only a narrow view of birth outcomes. And so we wanted to make a broader view in our measure. Lastly, because of these critiques, PSI 17 is not NQF endorsed, which really has limited its applicability by folks like the Joint Commission or Leapfrog or others, which really are looking for the standards in the Joint Commission. But it is easy to calculate because it does use purely administrative data. So in unexpected newborn complications, and we'll call it UNC from now on, just for shortness' sake, is looking only at live births that are singleton, that are normally grown, and at term. For PCO6, we are using ICD-10 codes for preterm and SGA. When we initially developed this, we used the linked data set with birth certificates, and we used the actual birth weight and gestational age on the birth certificate. We will later review the data to show that this is actually, we get almost identical data when we use ICD-10 for these exclusions or inclusion criteria. Again, we are looking at trying to eliminate pre-existing conditions for a healthy term newborn as a denominator here. So we have used ICD-10 codes for congenital malformations, and these have included most of the Q series codes in ICD-10, There are a few that were non-significant or terribly minor, like ear tags, that we did not exclude. A series of congenital disorders. These would be congenital conditions that weren't malformations, and these could be E and G codes, as well as placental and fetal conditions, congenital infections, intrauterine growth retardation, high drops, RH sensitization, and among others, from other sections of ICD-10. Additionally, as a pre-existing condition, we did exclude mothers who used drugs, and the babies were with withdrawal symptoms. And so these are a series of P codes. All of these are present in the neonatal code set, and so this allows for calculation of this measure only from the patient discharge diagnosis files for the baby. It no longer requires linkage and no longer to the birth certificate or the mother's file. This slide shows the distribution of exclusions. The yellow numbers on the right-hand side show the proportions excluded, for example, multiple gestations. And this was 8 months of California data with 230,000 births. We have a lot of multiple gestations in California. 2.8% were excluded. The next two purple boxes showed exclusions for low birth weight and low gestational age. And this includes a series, about 8%, which is our preterm birth rate. And then congenital anomalies is a typical number of about 3%, and other fetal congestions 1%. And then babies that had drug use in California that weren't in the above groupings was a little over 0.5%. These numbers may vary state to state depending on local conditions, but we anticipate that between 80 and 85% of births would fall into our denominator. So this is important because this would allow us to look at a large number of babies to look at the a relatively low rate of complications. We really wanted to divide the complications, the unexpected newborn complications, into two overall categories viewed from this perspective of the family. And so we have divided the measure into two parts, somewhat similar in size between severe and moderate. Severe was defined from the parent's perspective, and we did focus groups on this initially. Would I be fearful of my baby's survival or long-term outcome if my baby had X or Y? Frame 2 is, would I be upset if my baby had, even if I didn't fear long-term survival? Note that the concept of preventability is not used here. This is, and again, the expectations of the woman and her family is that we've eliminated all the pre-existing conditions for the baby, and I'm expecting a good outcome, and I had either severe or moderate complications. Now, as was pointed out earlier in the discussion with the ARC PSI 17, administrative data has some limitations that we have to pay attention to. And the devil is always in the details with administrative data-based measures, but they are easy. They have minimal data burden, which is really important if you are looking at trying to do a measure in which you don't want to do any chart review on or do any sampling on. So we've gone to great lengths to provide safeguards for overcoding and undercoding, which are the two big issues with administrative data. We've also separated out severe from moderate like we discussed in the previous slide, and that was critical for face validity. You don't want to have a lot of moderate complications in competition with the ones that are really severe. Furthermore, we have found it very useful to break the complications into diagnosis categories. We call them internally buckets of diagnoses, to which this really helps focus the areas for quality improvement and facilitates quality improvement projects. So let's look at some of these strategies. After examining the coding practices for hospitals around the state, there was practices that became apparent that, shall we call them, had special needs. Overcoding. Early on, in the first year, we saw a number of cases of sepsis, newborn sepsis, that had very short lengths of stay, i.e. 2 days, 3 days. You don't really have sepsis if you're going home in 2 days. And what became apparent is that coders were looking at the neonatal record and seeing rule-out sepsis as an admission to a NICU or elsewhere, and they coded it as sepsis. So we were able to add a requirement for this particular code or series of codes that if you're going to be considered significant as sepsis, you had to have a newborn length of stay of at least 4 days, 4 days or more. Now you can also undercode. There are some hospitals that don't code a lot. And we wanted to also look at places that had some limitations of which diagnoses they recorded. For example, in some hospitals in our state, certain codes that had medical legal liability issues were typically undercoded or excluded from coding. For example, hypoxemia or birth asphyxia were irregularly coded in some facilities. However, procedure codes were almost always coded because they're tied to billing. And there are often procedure codes that go along with the diagnosis codes. It could be EEG, it could be CT scans or MRIs that give a different pathway to identifying a baby with a neurological concern. So we have used extensively both procedure codes and diagnosis codes for a complication bucket. For respiratory conditions, for example, we could include nitric oxide, ventilator use, ECMO, and we already mentioned the EEG. We also noted a number of moderate complications that were maybe important if they had a longer length of stay, maybe inconsequential if they had a very short stay. For example, a clavicle fracture or a baby that had a short period of CPAP. Those would, on the face, sound like a serious condition. As we know, clavicle fractures often just get slinged and heal well together without any further treatments, and may not actually represent any significant issues. And so we decided, after several years of experience with these, to only consider them a moderate condition if the baby stayed longer than the mother. And for this, we've arbitrarily set it length of stay of 4 days, over 4 days for the cesarean, over 2 days if the baby was born vaginally. Again, another approach for undercoding protection is that we had some cases that had very few codes, but very long length of stay, 5, 6, 7 days length of stay in term babies without any reason noted. So this was suspicious for a morbidity that just didn't get coded. Some of these clearly had what we would consider reasonable causes, such as jaundice and phototherapy was the biggest reason. These can be identified, though, and if they're present, we would exclude them. The second cause for long lengths of stay that were legitimate or reasonable would be significant social problems, homelessness, child welfare custody, the residential institution, things like that, where the baby really wasn't able to go home for no reason of its own. And these now have ICD-10 codes, and they can be excluded from the consideration. So what do we mean when we say severe UNC, severe unexpected newborn complications? There are four major categories. There are a classic list that I think everybody on the call would recognize as pretty serious complications: intracranial hemorrhage, hypoxic ischemic encephalopathy, birth asphyxia, Erb's palsy, EEG. These are all emblematic or symbolic of major birth injury or neurological complications. Likewise, if the baby gets coded for full CPR or gets arterial lines placed at term, these are pretty significant, even if it wasn't clear whether they were placed for respiratory or neurological injury. That's why we have a separate category of shock that picks up babies that aren't in either of those. Respiratory is an interesting one, because there were a lot of babies that get coded for RDS, even at term, that don't have a long length of stay, and that may not really represent a severe condition. So we went for those that were on a ventilator or had a chest tube, nitric oxide, pulmonary hemorrhage, and a few other like diagnoses. Infection-wise, these were not just rule-out sepsis, as we talked about, but actual septic shock or sepsis with an identified bacteria, again, with a length of stay of 4 days or more. Moderate UNC, for birth injuries, these have length of stay requirements, fractured clavicle, affected by, and there's a whole series of codes for affected by, breech delivery, forceps delivery. Again, these have length of stay requirements. Sometimes you get a CT or an MRI just for follow-up to rule out a congenital anomaly seen and potentially seen on ultrasound. So we actually wanted to have a length of stay requirements that the baby stayed more than the mother, 2 or 4 days for this to count. Respiratory was CPAP, RDS, pneumothorax, and with a length of stay modifier, transient tachypnea, which can be very minor, just a few hours, or it can be a more major deal. In infection, there was some sepsis with identified, but did not have any length of stay. So what's our typical frequency of these? And here I've shown you how it varies from NICU, among NICU levels, and this is California data for the full year of 2017. Said we've been using this extensively in California since the early 2011, 2012. And one might have thought that level 3, level 4 centers would have higher rates of unexpected newborn complications. And they were slightly higher in the first year or two. Now they're actually lower. The level 2, level 1 critical access hospitals, even the university hospitals, are all pretty much the same. This is the mean rates among these hospitals. We'll mention the ranges a little bit later, but this is the means. And the total UNC is surprisingly similar. The universities had a little higher rates, and we'll talk about that in a minute, for moderate, which means even though they're severe, they're saying their total were higher. But it ends up being about 3% of babies have either severe or moderate, of which a fair amount is severe UNC. So we do a lot in California about helping hospitals analyze why their rate is high. So let's drill down into a sample hospital. It's a university hospital, full year 2017. This is the total onc rate. And you can see in the orange are the hospital's actual rates and compared to the statewide rate in purple. The more solid colors are the severe rates. The moderate rates are in the fainter colors. You can see this hospital had actually lower rates of severe and higher rates of moderate than expected from the statewide rates. Statewide rates in this slide actually include all comers, not just university hospitals. So then we looking at the different buckets or the different diagnosis categories. This hospital had a little higher rates of neurological injuries, both moderate and severe, same in infection, higher rates of respiratory, and this is probably related to some of the coding practice for moderate respiratory that we'll talk about later. And of course, they don't have transports because it's a level 3, and they get transfers in, but they don't transfer out. So this could give them some direction about where to go, looking at that first category and particularly the moderate respiratory in that third category. So we've done a lot of post-market surveillance, if you would, of getting feedback from hospitals around the states that have been using this. What about this? What about that? Why is this coded? Why is this not? And it's really important not to just rely on what our expert panel thought about specific codes, but to see how the codes are actually assigned in the real world. And again, California has 240 hospitals, and Oregon and Washington add another more than 100, 120. So there's a lot of hospitals that have been giving us feedback on this measure. One example is what we saw, and this was actually a common issue among many university hospitals, is that the procedure code for non-invasive mechanical ventilation under 24 hours, which is CPAP, was being used by some hospitals for bag and mask resuscitation in the delivery room. I know, just for 30 seconds or a minute. So they were using this code so that bills could be dropped for a pediatrician in attendance. You know, they wanted to be able to bill for that pediatrician. They had to have a diagnosis code, so they were using this, even though it's not really CPAP. And so we ended up tweaking this so that it had a length of stay modifier. So you know, under 24 hours of CPAP only counts if you're staying more than 2 days for vaginal delivery or over 4 days for a C-section. We've done for NQF adoption endorsement. We've had to do a variety of other types of validation studies. We did space validity studies in which we compared directly the severe morbidities against actual hospital level data reported from NPIC, looking at their NICU admissions and their actual clinical data from a large number of hospitals on the East Coast. Informal reliability testing, and this is a statistical test that looks at both the amount of variation that you see and the frequency, i.e. It's a tougher test if it's a very low frequency event. And this is rated as good if it's above 0.8 and excellent if it's above 0.9. And when we did this in 220 hospitals in California, we had a reliability testing of 0.92, which was obviously reassuring. Also for NQF, we had to look at stability within a hospital over time. As if there's periodic, huge swings, that's not a very good quality measure. And we tested 3 6-month baseline periods before anybody was using this measure, and found that in over 90% of hospitals there was minimal variation, so the baselines was stable. In the last 2 years, we've done a series of projects. First of all, of course, we translated everything into ICD-10, re-examined the individual code frequency for every single code. There are hundreds of codes in this, but if you can imagine, for all the birth defects, everything else. And then we reviewed it again with our expert panel, and the ICD-10 version, we're happy to report, is within a tenth of a percentage point of ICD-9, so that trend lines are very acceptable as we've followed hospitals over time. The second thing to make this more widely usable is that we evaluated whether you could eliminate the birth certificate and the neonatal clinical data linkage, allowing for PDD alone. We did use APGARs initially in this measure. An APGAR under 3 was considered a significant complication. When we eliminated that, we had no change in rates. And there are a couple of reasons for this that are interesting. One is that babies with low APGARs often have other major complications. You know, they don't just have a low APGAR. They have a neurological or respiratory major complications. So they were picked up elsewhere. Secondly, if you had a low APGAR and absolutely nothing else, and you went home with your mother, it was probably somewhat isolated event. The baby was stunned at delivery, it got resuscitation and ended up doing fine. So that would really not qualify in and of itself as having a major, a serious or moderate complication. So there were very few of those and ended up not changing the rates. The bigger one I was worried about, to be honest, was the gold standard for birth weight and gestational age is the birth certificate. We do know that ICD codes were not perfect, and we were concerned that we were going to have bigger numbers of UNC because we would have more 35 or 36 weekers that weren't adequately coded as an exclusion. And we did see a small rise in only moderate UNC, but it was only a few tenths of a point in the rate, so we don't think that's a significant contributor. Overall, though, we really focus our efforts on quality improvement, and we think the most important part of UNC is the severe UNC. The moderate UNC is a little bit more sensitive to some of these other issues. So if we're going to put our money down, we're going to look at severe UNC. And that's what we use for quality improvement. And probably the most important use of UNC is as a balancing measure for obstetric quality improvement projects. And I want to emphasize that, and we'll talk about that again a bit later. And here's an example of 2 pilot hospitals in our first C-section initiative, where you can see in the blue line where C-sections start to fall, significant falls from mid-30s to mid-20s, 10 percentage points in both of these cases. What happens to the baby in that setting? These are term mothers who are working on NTSV C-sections. And you could see that the unexpected newborn complications, the severe rate, which is 1.5%, 2%, in the first hospital and a little higher in the second hospital, they both stayed the same or actually fell. We're actually reporting in the next 2 months, both at SMFM and in the Green Journal, a much bigger study of C-section reduction of over 50 hospitals that have shown with very large-scale reductions in C-section rates, you do not see any reduction, any increase in UNC, and actually there was trending toward lower rates of newborn complications with lower C-section rates. So stay tuned for that one. Other examples of using UNC for QI projects, and this is where I'm most interested in it as a QI leader. First of all, benchmarking for UNC categories leads you to a better understanding of where your hospital needs to work. Do you have more problems with neurological issues or infection issues or respiratory issues, for example? We've had hospitals identify themselves in this regard as having high rates of newborn infections. Some of that has been related to how they evaluate newborns for infection. We had several hospitals in California that were using C-reactive protein, which seemed to end up with a much higher rate of newborn infection and much higher rates of antibiotics and long stays. And they actually changed that with no change in outcomes, but improved their UNC rates. Likewise, this is a great way of following outcomes for forceps or vacuums and ensuring that the protocols that you're using for forceps and vacuums are up to date and are not associated with neonatal morbidities. Some of our hospitals have also looked at their neonatal resuscitation protocols. This second stage labor is a major issue now in many obstetric hospitals, how long you're going to let the mother labor. Is it 3 hours, 4 hours, 6 hours? This is a measure that's been very useful for doing QI projects around labor practices. I think most importantly, this expands our ability to identify cases for in-depth review. In many of the perinatal committees that I've sat on in 5 hospitals for over 30 years now, in the past we had to use low APGAR scores or admission to NICUs or things like that. And this really allows you to say, okay, which babies had unexpected major complications? Let's look at those cases for opportunities for improvement. And lastly, as I said in the last slide, I think the most important use of UNC is going to be as a balancing measure for OB intervention studies. And that actually is the intent of the Joint Commission adoption of UNC, is they already have the NTSV C-section measure, PCO2, and they want to be able to say, yeah, we're looking both at mothers and babies together. And so this is a balance then. If you're looking at mother outcomes, you want to be able to look at baby outcomes. And this is a way to be able to do that balance. So, UNC represents and reflects a patient and family viewpoint, but also has face validity with physicians that we tested at the very beginning. There's actually more variation than expected among hospitals, and more improvement opportunities than potentially I might have thought of at the beginning. It is sensitive to both obstetric practice and neonatal care practices. So this is truly a joint perinatal quality metric. So it is a validated term baby outcome measure that's been in use for 8 years or more. You're able to drill down and examine reasons for higher levels and identify improvement opportunities. And it's really important as a balancing measure for primary or NTSV C-section QI projects. My last 2 slides are going to be some FAQs that are often asked as we've used this over the last years. First off, what proportion of hospitals' births are included? We talked about this in the very first slide, where, with the pre-existing condition exclusions, we're still including 80 to 85% of all births. So this generates a sufficient volume to be able to look at a rate that's about 3%. Do hospital types have significantly different rates and hence are inherently disadvantaged? Here what we'll see, and we'll talk about variation in a moment, there's large variation among hospitals of all types. The means and ranges within the categories of hospitals, whether you're level 1 or level 4, are quite similar, indicating at this point that there's not risk adjustment needed for term babies. So what is that variation that we spoke of? Total UNC in 2016 to 50th centile was 27 per thousand, or 2.7%. The 25th centile was 19 per thousand, and 75th centile was 37. So it ranged from 1.9 to 3.7% for the 25th and 75th centiles. That means that there were another 25% that were quite a bit lower, and another 25% that were quite a bit higher. Similar variation was seen for severe UNC. And again, we saw this variation in all levels of hospitals. So the means were almost identical for all the types of hospitals as shown earlier. What are the diagnosis categories that drive UNC? In California, and in our other states, the most frequent category is respiratory. This California data, this is over just about 1% of births, or 10 per thousand, are fit the UNC category, respiratory category. Transfer to another hospital, which is of course something that you see in level 1 and level 2, is at 8 per thousand, infection at 6 per thousand, neonatal birth injury at a little under 4, and long length of stay about 1 per thousand. So not surprisingly, term babies have issues with respiratory and infection, and transfer if you're a smaller hospital. So why are hospital transfers included? The three significant issues here to discuss. One is, and transfers are considered severe because they usually represent a serious neonatal issue that dislocates the family from the baby. It results in a major disruption and concern for the family. That's, when you talk to family, that's a big deal. Secondly, or B, neonatal coding in the birth hospital for a neonatal transfer is actually quite limited. They don't really give the reasons for the underdiagnosis because oftentimes they don't know the diagnosis. It's really then worked up in the tertiary center and a diagnosis given there, but that's not present or really accessible for this. Thirdly, we really are only focused on transfers to higher levels of care, not back transports if any of those occur. So you need to pay attention that only it's to higher levels of care. We had a couple questions over this last year about what about infants transferred who at the tertiary hospital were found to have a congenital anomaly, which would have counted as a exclusion. First of all, this doesn't happen that often, where the anomaly wasn't recognized in the first hospital, but if it was unrecognized and required a transfer, that's often represents a perinatal quality improvement opportunity, i.e. a missed major diagnosis. And so we really want hospitals to pay attention to that as well. What about if the long length of stay is due to the mother, i.e. there's certainly mothers who have a prolonged postpartum length of stay due to conditions like preeclampsia. But if the baby is normal, most insurances require that the baby be discharged and either stay as a rooming in or go home with the family. So you really shouldn't have a long baby length to stay even if the mother has preeclampsia with poor blood pressure control. So one of the advantages of being a grandfather is that you get to show pictures of your grandson at birth here, and we were blessed with a healthy term newborn, so I'm happy to show. So I'd like to stop and see if we have time for questions in the last 10 minutes. I'm happy to take any that you have.
Thank you, Elliott, very much for that presentation. We have lots of questions, so I'll just start going through them, and some of them may have already been answered, but I don't want to eliminate any just in case. So first couple of questions, will this measure be a random sample estimate of a rate like PCO1 or include all the patients who meet the criteria? And is JACO dropping PCO1 at the same time as adding this new measure?
So one of the advantages of having this be administratively data derived is that it's not a random sample. It's the full sample of term babies. So it's done automatically by analysis of the codes. PCO1 is not being dropped at this point. That's really that's the rate of early elective deliveries. And so it's a different issue. We seem to be doing better on that nationwide, and that's so it may in the future be dropped, but not this year.
So for the exclusions, which infections are covered underneath that?
It's any bacteremia. In an ICD-10, you identify the bacteria. So bacteremia, septic shock, but that includes immediate neonatal infections like Group B strep. There's a fairly long list there, but they're all specified within the criteria.
Okay. Has the cooling cap procedure been included?
Yes.
Okay. And you may have answered this, but how does the coding work when hospitals immediately transfer newborns out of the NICU to a different facility? If the NICU is on site for delivery and immediately assumes care, is there a cross-tracking between the delivering hospital and the receiving NICU?
So if the baby gets transferred from one hospital to another outside the four walls of the hospital facility, that's what we are concerned about, a newborn transfer, and that would be counted as a severe neonatal morbidity. Where we've had some issues in California, and I'm not sure if this is true in other states, is that in California, children's hospitals get paid a premium for the care they provide. And that has led to children's hospitals essentially purchasing NICUs in other hospitals, affiliated hospitals, and setting up a children's hospital NICU under a different license for reimbursement purposes. And that means that the baby is discharged from hospital A to be admitted to the NICU under the different license, but that is technically a transfer, but it's within the four walls, and that really doesn't meet the intent of what we're trying to capture here. And so we've been working with those hospitals to identify so that they can not have those counted as a transfer, but we want to capture the diagnoses that are generated in the NICU stay to make sure, because that's only fair to that facility, for them to be able to understand what happened to their obstetric cases, because these are in the same building. It's just the NICU, for financial reasons, has been sold, if you would, to a children's hospital. So that's the only issue outstanding around transports.
There's a question about understanding the higher rate of birth trauma among cesarean-born babies versus vaginal babies. Is there any analysis about that?
That was a finding of that earlier study using that earlier metric. And I think that's one of the discrediting factors for that measure. We do not recommend PCI 17. I think that was partially because nicks in the scalp at C-section were being coded as other birth injury. There's a whole variety of potential reasons for that. The Erb's palsies were excluded from that measure that you typically see at vaginal delivery. A few at C-sections, but most of those are vaginal births. And so that measure is flawed in many ways. And so I would disregard that measure completely, that finding.
Okay, now there's a couple of questions about length of stay. For the child length of stay, is there a way to untie it from the mother's length of stay? And then what if the baby stays in the NICU for a couple of days, but then the mom stays for longer? And then how does that work with the baby falling out if it has a long length of stay, et cetera?
Well, this is really focused on the baby's length of stay. And again, if the baby's ready for discharge, in most facilities, they are going to be discharged to rooming in or go home with family members. If the mother has to stay for 8 or 9 days in the hospital, the baby's not going to be an inpatient for 8 or 9 days in most facilities, or shouldn't be. Considered they shouldn't be billing for that. And that's really the issue. So yes, the baby could be in the NICU for a couple of days and on the floor, but this is recognizing that they wouldn't be considered an inpatient for the whole mother's length of stay unless they needed it.
Okay, and regarding maternal drug use, should babies only be excluded if they were directly affected by the mother's drug use, such as cocaine, meth use leading to placental abruption or opiate withdrawal requiring treatment, or should all infants with in utero drug exposure be excluded? And does this include marijuana?
So marijuana is not an exclusion at this point. We're still trying to understand fully the impact of marijuana. Certainly cocaine, there's new codes for opioids directly describing opioids. And there are codes saying baby affected by opioids, baby affected by cocaine, and neonatal withdrawal syndrome. Those are the codes that we're looking at.
And what about
again,
THC? Sorry?
That THC or marijuana is not on the list at this point, and we're still learning about that. So stay tuned for that one. But again, this is they form a category in which the expectations are quite different than it's a form of a pre-existing condition.
Okay. Will the UNC measure count for delivering hospital or the hospital transferred to for the treatment codes?
It's the delivering hospital.
Okay. What if the baby has moderate respiratory UNC, stays 2 days in the NICU, but then stays 5 days with the mom? Again,
if they're normal, they shouldn't be in inpatient status for those additional 5 days. They would be a rooming in setting.
Okay.
Go ahead.
How do you count cases that fall into one or more complication buckets? Are they double counted?
No, there's a hierarchy. And at the top would be neurological injury. I think it then falls birth injury, neurological injury, and then I think it's either respiratory or infection. I've forgotten the algorithms, but they fall into one or the other. But that's a secondary analysis. The most important analysis is severe versus moderate. The buckets are there to help you identify where to put your efforts. And that's often determined internally. It's done in our data system in Washington, Oregon, California. And it's a helpful, but it's not required.
There was like a lot of question about differentiating between severe and moderate, and I think you may have covered that in your presentation, but the questions about coding for that, how do they can account for that?
It's major conditions. And there were a couple of slides on that. The Joint Commission specs laid that out very cleanly. And I would defer you there because there's a long list for both.
How do you compare the NTSV cesarean rate with the UNC rate since they are not necessarily in the same patients? While they overlap, there are cases, etc.
But in our data center, we're able to do UNC among NTSV. And they are not exactly the same, but we were able to do in our data center the exact same UNC among NTSV patients. NTSV is termed singleton nulliparous, so UNC would include multips as well as nullips. And NTSV does not exclude IUGR babies, for example, or babies with drug use. So UNC is a little bit more focused on the very lowest risk patients, but it is slightly different, but it's a reasonable balancing measure. You can define it even more closely for a QI project, for a formal QI project, to be the exact same denominators.
Let's see, how do you account for perinatal deaths addressed in this measure?
Sort of interesting. We worried about that initially, but there were, among term babies without pre-existing conditions, i.e., and no IUGR, there were very few neonatal deaths. Like out of 500,000, 15 or 20. Because those neonatal deaths really occur in other settings. All term neonatal deaths are going to get very carefully scrutinized. I mean, that's an RCA. And so we felt those would be handled from a quality standpoint in that manner, rather than to go in the measure. And so it does not appreciably change the count, the numerator count, if you included or excluded those. It is easier often to collect it based on live births. Go on.
Okay, I think that we are at time, and there are enough other questions that would be important for us to go through them outside of the call today and respond to people individually. So I will capture the questions and work with Elliott and get some answers out to people. I think a lot of the questions that are posed have been answered during the presentation. I want to thank everyone for being with us today and thank Elliott again for his presentation. And for those who might have missed it, the slides will be posted on the CMQCC website, and the call has been recorded and will be available in a couple days on the CMQCC YouTube channel. So thanks again for joining us, and we look forward to addressing any questions you might have as we move forward in the next day or two. Thank you to everyone.
Bye-bye.
Bye.